Hello everybody, and for this week we are going to be talking about somatic symptoms and dissociative disorders. Okay, so kind of interesting, up to this point we've discussed things like affective disorders, depression, mania, we've talked about anxiety disorders, and many of those disorders are more common. We can kind of relate to those disorders if it's anxiety ridden or depression and that kind of a thing. Now we're going to be talking about some disorders that are not so common and really hard to kind of put your mind around on how some of these things develop, or are they real disorders or manipulation by the individual, and so kind of a fascinating chapter. So let's get started. Here, an overview, we're going to be talking about somatic symptom disorders, which involve physical symptoms and complaints, and contain no evidence of physical pathology. Okay, so physical complaints with no physical pathology or cause, I guess, as well. Dissociative disorder involve physical symptoms and complaints as well, but here is more of a feeling of being out of it, like memory deficits. We'll talk a lot more about dissociative fugues and things like that. Remember that soma is body, so anytime we're looking at somatic symptoms, we're talking about bodily symptoms. If we're talking about psychosomatic, we're talking about the psychological components and how the psychological components affect one's body. Psychosomatic. So here we have bodily symptoms cause significant psychological distress and impairment. So here, the bodily symptoms come first, and the psychological distress second. Maybe medically explained or unexplained, and patients have no control over their symptoms. When we're talking about, again, this is just an overview, and then we'll break down each one later. But some of the most important disorders here for somatic symptoms is somatic symptom disorder, which is also known as hypochondriasis. You have illness anxiety disorder, conversion disorder, and then factitious disorder. So let's start with the somatic symptom disorder. This is chronic distressing somatic symptoms. Okay, so chronic distressing bodily symptoms. Dysfunctional thoughts, feelings, or behaviors accompany those bodily symptoms, and there's a high level of anxiety about one's health or symptoms. Some causes here could be prior experiences with illness. Some people have been through just an amazing amount of different medical procedures and medical stays in hospitals and everything, and you can think to yourself that that's really could definitely scar somebody. And so when something normal like your foot falling asleep or something like that, for you and I, we kind of shake it off and keep going. But these people, they've experienced, their prior experience has been so negative that oftentimes they feel something and then catastrophize it because no, it's coming back. And that's a completely logical viewpoint for them and their perspective. Okay. Negative affect, attentional bias for illness. So here's one where, again, kind of like what I was talking about, but to this extent, when it becomes a disorder, is irrational. Okay, so these are the people that oftentimes seek out what might be wrong with them. Absorption into one's experiences, again, very, very hyper-focused on, their fingernails they have little spots in their fingernails or something like that, and it's detrimental. This is a huge problem that I'm going to have now. Alexithymia, inability to identify one's feelings. Okay, so those are all causes of somatic symptom disorder. And here's a good diagram for you. So attention to bodily sensations at the very top. They think my stomach hurts and feels funny. Attribution of sensations to illness. Something is wrong. I must be sick. Maybe they're hungry, right? Maybe it's something that they ate and it's going to pass. But they think something is wrong. I must be sick. So they worry. They catastrophize. Do I have an ulcer? Could this be stomach cancer? And then they go to help seeking. I need to see my doctor as soon as possible. Okay. Treatments here. Cognitive behavioral treatment is key because it's a way of changing one's thought pattern. But relaxation training as well, validation that the pain is real, but not detrimental, I guess you could say. Real in the sense that, yes, like if the doctor tells you, I feel the same thing. I've experienced the same thing that you're experiencing, and it will go away. Okay? So there's validation that what you are feeling is real, but it's not going to have this long-term effect on you like you think it is. Increased daily activities, cognitive restructuring, no pain behaviors. Again, that's with the cognitive behavioral treatment. And then on the medical side, seeing patient on a regular basis with focus on new complaints. And then minimal diagnostic tests and medications are really out there. Primarily they're using antidepressants. That's about it for right now. Okay, what about illness anxiety disorder? High anxiety about having or developing a serious illness occurs for at least 6 months. Again, remember, disorders are on a continuum. We're not talking about something that lasts 1 or 2 days or 2 weeks. These are things that last a long period of time and interrupt that person's life. Ability to cope, ability to interact with their family, ability to hold down a job, things like that. No somatic symptoms here, and if there are, they're very mild. So this is kind of like this is an underlying anxiety about them being ill. There's also conversion disorder, neurological symptoms in the absence of a neurological diagnosis. Symptoms or deficits affecting sensory or voluntary motor functions. And we'll talk about these more in the next slide. So what are some of these sensory symptoms or deficits? They could be visual, auditory, sensitivity to feeling. For example, loss of feeling in one hand. They could be motor related, unable to talk or write with the hand. They could even be seizures that resemble epilepsy, but when they undergo medical tests, they see that they are not true seizures. And there could be a mixed presentation of all three. So here's where it's a good example of how I started this lecture with, it's kind of hard to put wrap your mind around, right, on some of these disorders. How could somebody be have a seizure that's not truly a seizure? How could somebody lose feeling in one hand? So it's very, very odd cases, odd disorders here that we're looking at, but nevertheless very, very important for that individual so that they can have help overcoming these disorders. Okay, so an accurate diagnosis for conversion disorder is a dysfunction does not conform to symptoms of the particular disease or disorder simulated. So again, yeah, if that person has epilepsy, then we're going to treat them with epileptic medications and so on. But this is a dysfunction that does not conform to the symptoms. So it's not epilepsy, but it's a type of seizure. We have to diagnose it as something separate, and then treat it as something separate. Highly selective nature of the dysfunction. So here, in this case, it could be blindness. These individuals, they appear to be blind, but they don't run into things. Okay, which somebody who's truly blind would, especially somebody who just um, all of a sudden became blind. It wasn't a due to like a degeneration or degenerative disorder where they lose their sight over time. But if they just all of a sudden lost their sight, you would be bumping into everything. You wouldn't know where to move around. Symptoms can usually be removed under hypnosis or narcosis, which is a sleep state induced with drugs. Okay, so again, if this was an issue with the individual's eye itself, being unable to transfer that physical energy of light waves to the brain, or if it was something in the occipital lobe where where the centers are for vision, if that was disrupted, you wouldn't be able to, under hypnosis or narcosis, remove the symptoms. Prevalence here, approximately 5% of people referred for treatment. Highest estimates have been around only 0.005%. Extremely small. Patients often medically unsophisticated, so when they come in, maybe they don't have the literacy, they don't have the ability to really research stuff, understand what they're reading, that kind of thing. Occurs 2 to 3 times more often in women, and most commonly occurs between adolescence and early adulthood. Okay, there's another component here with gains. When it comes to conversion disorders, there's primary and secondary gains. I want to read something to you here. According to the Freud's view, says the unconscious conflict that a person felt about his or her repressed sexual desires is at the forefront here. However, in Freud's view, the repressed anxiety threatens to become conscious, so it is unconsciously converted into a bodily disturbance, thereby allowing the person to avoid having to deal with the conflict. This is not done consciously, of course, and the person is not aware of the origin or meaning of the physical symptoms. Okay, so remember, this is just a Freudian view. This is a psychoanalytic view. But Freud continues and says that the reduction in anxiety and intrapsychic conflict was the primary gain. So the primary gain of conversion disorder is this reduction in anxiety and intrapsychic conflict, right? But he also noted that patients often had many sources of secondary gain, right? Such as receiving sympathy and attention from loved ones. So that would be your secondary gain, is that attention that one gets from loved ones or family members. Okay? Then we go to treatment. Behavioral therapy, increasing movement with praise and reinforcement. Remember we talked about not being able to move or loss of all feeling in one hand or something. You'd want to increase the movement as much as possible. CBT, critical here, and then hypnosis has shown some benefits. What about factitious disorder? Okay. The person intentionally produces psychological or physical symptoms, or sometimes both. The goal here is to obtain and maintain benefits of playing the sick role. And many of us have heard about the disorder Munchausen syndrome by proxy, and this is the factitious disorder that is imposed on others. So this is the individual who wants to play that sick role, right? But instead of making themselves sick, they make somebody else sick, so that they feel that, oh well, my daughter is so ill, I can't do anything whatsoever. All I can do is sit here by her side and take care of her. And then through that, they also get all of this emotional support, family support. Okay. Dissociative disorders. Okay, now these are also hard to wrap your mind around. We're going to go through a couple of these, but again, and with this material here, it would probably be good to go back through your textbook also, and just kind of, because you read the PowerPoint slides and you think you understand it, but you might need some more information out of the textbook for reinforcing some scenarios and things like that, so you can better understand it. But okay, so these are disruptions in normally integrated functions like consciousness or memory or identity, perception, or motor control. Okay, so disruptions in all of these, or at least one of these things. Okay, integrated automatic non-conscious processes. So implicit memory. If we step back a little bit, explicit memory is going to be memories that you can recall. Memories that if somebody asks you a question, what is the capital of some country, and you state it immediately, that's explicit memory. That's, you're able to declare that in an outward manner, right? Implicit memory is something to the effect of like working on a puzzle where you've done puzzles before, so you can do puzzles quicker. There are individuals that have they lack a lot of short-term memory. So you ask them, have you ever seen this puzzle before? And they say, no, I've never seen that puzzle. But in fact, they've actually put that puzzle together maybe 10 or 15 times. They just don't realize it because of that short-term memory. But now they're putting that puzzle together quicker and quicker each time because there's still an implicit memory. Okay. So remembering things you cannot consciously recall. I can't recall ever doing this puzzle before, but I am remembering how to do the puzzle because I'm doing it quicker. I know that's kind of a hard concept also, but that's implicit memory. Implicit perception. Responding to sights or sounds even though you cannot report having seen or heard them. Okay. Types of dissociative disorders, really, is what we're talking about here. There's depersonalization, which is a sense of self and one's reality is lost. There's derealization, sense of reality with the outside world is lost. Dissociative amnesia, which is a retrograde amnesia, which means that you have a hard time remembering things from your past. And there's also dissociative fugues. Every once in a while, you'll hear a story in the paper, on the news, where this individual has just left their house. A dissociative fugue is or they call it a fugue state, is when they're completely confused, they don't know where they are, and they just start walking away. Okay? And they forget how to get back home or where they are. And then there's dissociative identity disorder. We're going to go in more detail on that now. Okay, characterized as disruption of identity by two or more distinct identities or personality states. So this, you've seen some movies probably on this, where they have multiple personalities. It used to be called multiple personality disorder, but now it's called dissociative identity disorder. Recurrent episodes of amnesia and self-reported or reported by others. But these are the individuals that have the multiple identities. Now, some controversies behind dissociative identity disorders. Is the disorder real or faked? Really hard for us to tell, right? How do we know that this other identity, this other personality keeps coming to the forefront? Or is that individual, are they very, very good? Because you'll see these different documentaries about, one personality will have an accent, or one personality will, talk in different ways, be very terse with their speech or forceful or something like that. Another one is very petite in their speech. But can an individual be playing that role That's the question. If the disorder is not faked, how does it develop? Because we don't know what that is. Are recovered memories of abuse in the disorder real or false? That's a key question for us. And if abuse has occurred, did it play a causal role? So just because there was abuse in the past, is that the reason for these other personalities to come to the forefront? Okay, my e-lecture topic item is listed there for you. If you can fill that out then and respond to it when you respond to the discussion thread. Thank you. All right, only a couple more here. This is a fascinating graph figure because on the x-axis you have sexual abuse and you have physical abuse, and on the y-axis you have percentage. So reported childhood abuse in 4 separate studies. So you have the Poopman study represented by purple, the Ross green, Coons yellow, and Ross blue. And look at these rates for sexual abuse. So individuals with reported cases of dissociative identity disorder range from about 70 to 90% having been sexually abused. And we're looking at between 60 and 82% have been physically abused. So that is a pretty amazing statistic there. We're looking at 488 cases also. So that's a lot of cases. It's a very, very high percentage. Okay, and then we end here with treatments for dissociative identity disorder. You have hypnosis. You have the repetitive transcranial magnetic stimulation, which they can do. It's a non-invasive technique that has been becoming more and more popular. Remove the environment, remove the individual from the environment. We have antidepressants, anti-anxiety drugs, as well as antipsychotic drugs working there. And then therapy to work through the trauma. And again, cognitive behavioral therapy and things like that. Okay, and that's it for this chapter. Thank you.